Yeah.
Just more detail there.
That's right.
Okay, yeah, think it better, right? How school work is all about. Okay. And you follow the steps and then you would have to. I'm here.
Good morning. How are you?
So I got everything they did. Okay, all right. Your funding. And it took 2 years.
Yes.
And John, you're there. We missed you.
All right. We're about to get started here in a few minutes. We're about to get started. We're about to get
I
started.
want to announce that we have a breakfast.
Yeah, we already announced it.
Oh.
Good morning, everyone. Good morning. We're about to get started. For the interest and sake of our agenda and for time, we know, as always, in beloved Spartanburg, we'll have a few stragglers coming in a little late. And we also know that as much as we all do, we'll have a few people rolling out a bit early. So with that said, I wanted to get started. Welcome. Good morning, everyone. My name is Midas Hampton. I have the pleasure of serving as the founding executive director of Strategic Spartanburg. It is truly an honor to welcome you here today on behalf of Strategic Spartanburg as we begin with a sincere thank you for your presence, your partnership, and most of all, your continued commitment to our young people. This morning marks a milestone in our shared journey to better understand, support, stand with the youth of Spartanburg County. Today, as we release the State of the Youth Mental and Behavioral Health Research, a report that is grounded in data, shaped by community insight, and perhaps most powerfully, voiced by the youth themselves. We often say that data tells a story, but in this particular case, the story is urgent and the storytellers are clear. From rising rates of persistent sadness and suicidal ideation, particularly among our female Latinx students, to deeply rooted disparities in access, stigmas, and understanding. This report illuminates not just statistics, but real lived experiences of youth in our community. And we found that both sobering and galvanizing. It's not just about the risk factors that we have, it's also about the protective factors. How do we protect our youth? School connectedness, family support, sleep, movement, trust. It's about the power of being seen, being heard, and held, especially in times of distress. And it's about how often, tragically, these protections are unevenly distributed amongst our youth. But what makes this work different, what makes this moment different is the inclusion of young people not as subjects in research, but as partners in the process. Their words, their wisdom, their willingness to show up and share stories have transformed this project from research to a call to action. They told us, we don't know what's out there. We don't know where to go. And I think probably most profoundly, we don't know who to trust. And just as clearly as they told us what they need, what's the issue, they also told us what they need: honest dialogue, peer-led spaces, culturally relevant resources, and the assurance that they are not alone. So today we're going to go over a few things. You'll see some quantitative data, and you'll see qualitative results. You'll also see policy and practice implications, and we'll have a panel discussion that really touches on a lot of these issues overall. At Strategic Spartanburg, we leverage our 4 pillars of impact to do this work. We look at the data and disaggregate to find where the disparities exist. We drill down on those disparities and research with those communities in order to understand it better. And then we leverage the findings from those research opportunities for policy and practice implications. But all those things mean nothing if we do not know we've moved the needle. And so our evaluation and measurement pillar is one of the foundational hallmarks of the work. My team, I want to give a huge shout out because they were phenomenal, have been phenomenal. Dr. Hussein, Sarah Buckmaster, Tennille Black, Joshua Todd, Ariana Grant are the people behind this work. And so I wanted to make sure you all saw the faces because I'm typically the one standing up giving the reports. We really looked at a few large questions in this research. What are the root causes that are driving this? What are the risk and protective factors associated? What processes socially, these processes and mechanisms that are most salient? And how do the youth in Spartanburg conceptualize solutions themselves? And so that led us to our mixed methodology. We understand that data outside of context is a lot of noise and not a lot of solution. And so what we like to do is pair quantitative with qualitative methods. And we did a secondary analysis of the YRBS 2022 data, looking at the relationship, the statistical significance of these relationships. And then also we had several focus groups with youth in Spartanburg from around the county. This report and this event is not the end. It is a beginning, a conversation starter, a moment to pause, reflect, and recommit. So I ask that what we learn here move beyond meetings into mentorship, into systems change, into spaces where every young person in Spartanburg feels supported and feels free to fully be themselves. To our community partners, we say thank you. To our research team, we say thank you. To the youth who bravely share their voices, thank you most of all. And without further ado, I would like to say welcome to the launch of the State of the Youth Mental and Behavioral Health Report. And at this time, I would love to welcome up Dr. Hassan, the Director of Research and Evaluation at Strategic Spartanburg, who will lead us through the quantitative section of the report.
Thank you, Dr. Hampton. So good morning, everyone. I'm happy here today to share quantitative findings of our research project on youth mental and behavioral health. So let me show you some findings that we have through our quantitative data analysis. So here is the overview that I'm going to talk about in the quantitative part of our observations and findings. So basically, we did our analysis based on what's called YRBA's data, youth risk and behavior health data. That is a survey data that was conducted among the high school students across Spartanburg County. So this is the representative sample. About 1,100 students were sampled from the overall population of high school students across Spartanburg County. So we did our research on that sample that represent the whole population of high school students in Spartanburg County. So what we are going to look at today is like how prevalent is the problem, or what is the magnitude of the issues that we are trying to address. So so we have our prevalence part of our findings, and then we observe that, and we all know that these social problems related to mental well-being or mental health problems are not evenly distributed across all social groups. Some groups experiences higher levels of problems than the other groups. So we look at the disparity and the magnitude of the disparity, and then one of our major statistical analysis involves identifying the risk and protective factors that are statistically meaningful or statistically significant. So when we mean statistical significance, this means that we are quite confident about our findings, that these findings are not caused by the random chances, but by a clear general pattern. So risk factors are those that increase the likelihood of mental health problems, and conversely, protective factors are those that protect young people from mental health problems. Many of these factors are modifiable risk and protective factors, meaning that from the individual level to the higher stakeholder level involving families, communities, they all can have a significant role to play in addressing these risk factors and in promoting protective factors. So, and finally, what we observe is that not only those mental health problems are unevenly distributed, but also we observe that the factors that cause it are also unequally distributed. So we'll see that disparities exist in lifestyle factors that are associated with mental well-being. So in our YRBS data, that survey included 3 mental health outcome questions. So we all know that mental health has like this can be defined and conceptualized and quantitatively measured in many different ways. There are stress, anxiety, depression, other types of mental health disorder. However, what YRBS survey does is kind of capture the overarching phenomena of mental health problems through these 3 outcomes that include persistent sadness, poor mental health, and suicidal ideation. So in terms of the persistent sadness, students were asked, during the past 12 months, did you ever feel so sad or hopeless almost every day for 2 weeks or more in a row that is you stopped doing some usual activities? And they're given the options, yes or no. And 40% of the high school students in Spartanburg County reported that they experienced persistent sadness, or they said yes. And then we have 40% poor mental health question that asked students during the past 30 days, how often was your mental health not good? They were given the option from never to always, never, rarely, sometimes, most of the time, and always. So what we did is to look at the students who reported that their mental health was not good most of the time or always not good. Like 32% students reported that their mental health was most of the time or always not good. And then the third variable that captures mental health problems is suicidal ideation. And 16% of the students reported that they seriously considered attempting suicide. So they were asked to respond to a question related to sadness that during the past 12 months, did you, so for the suicide, during the past 12 months, did you make a plan about how you would attempt suicide? So they are given the option yes or no. So 16% of the students reported that they reported yes to this question. So we have seen in a nutshell a high prevalence of mental health issues among the high school students in Spartanburg County. Okay, so now we have also tried to look at some temporal trends because we have 3 years of data. It's not longitudinal data, meaning that the same subjects were not observed over time across these 3 time points. But we can get a sense out of this data because it started from 2019 and then 2021 and 2022. So as you can see in this graph, in 2021, you see a little spike in all 3 indicators. For poor mental health, the middle line is basically it has like 2 years of data. So we did not include that question in 2019 survey. So however, we do not know why there was a spike in there, but we suspect that this is related to the pandemic that might cause increase some of the risk factors, for example, the screen time. So we'll talk about that, how screen time is related to mental health problems. And we do not believe that this is a very significant increase or decrease. So it's just a small spike in 2021, but that stabilized in 2022. So similar to the base level, which is in 2019. Okay, so now we look at the disparities. We look at the disparities by gender and ethnicity, by race. So as you can see in the first graph, gender disparity. So what you see is a big disparity between male and female students. So, and we also run some chi-square tests to see if the difference is statistically significant or not. So we found that they are statistically significant. 53% female students reported that they had experienced persistent sadness compared to 25% male students. So that's more than double like female students. And this is the bivariate statistics, but we also do it in the more sophisticated regression modeling to see if we include like other control variables, we still see the relationship exists. And then we have a significant difference between Latinx student and non-Latinx students. 48% Latinx students reported that they experienced persistent sadness compared to about 39% non-Latinx students, and that difference is statistically significant. And also we have the racial difference. So what we do is we compare all other groups with white students. So white students, 37% white students reported that they experienced persistent sadness, and we compared it with other racial groups. So, for example, Black students, 46%, multiracial students, 47%. So we compared it with white students, and we see that these differences are statistically significant. So what we observe is that there's a significant difference by gender, by Latinx status, and by race or ethnicity. So, and we also not only observe for the persistent sadness, but we also observe similar patterns in terms of suicidal ideation and poor mental health. So in terms of the suicidal ideation, you can see the huge difference between male and female. 22% female students reported that they experience suicidal ideation compared to about 8% of male students. And we see a significant difference between Black students compared to white students. Like 21%, about 21% Black students reported that they experienced suicidal ideation compared to white students. They are about 14%. Same pattern, but we didn't see much difference. Like we see differences in racial differences and also Latinx and non-Latinx differences, but we didn't find statistically significant difference. So what we find in terms of the poor mental health is a significant difference between male and female. So female, about like 40% female students reported that they experienced poor mental health compared to 19% male students. So overall, in terms of the disparity, like female students across all three mental health outcomes have significantly higher levels of experiences of mental health problems compared to male students. So now we have looked at the prevalence and disparities by race, ethnicity, and gender. And now we run some regression analysis to see if we include all the variables, control variables together, we still see the differences. So that we have more robust finding in terms of identification of those disparities, and also identifying the risk and protective factors. So in our regression model, that is for three different outcomes. So for the two outcomes, there was like binary response questions, yes or no, for suicidal ideation, and for persistent sadness, we run logistic regression model, and then for the poor mental health, that was the ranked outcome from 1 to 5, like never to always. So therefore we run ordered logic model. So and therefore we have the log odds and regression coefficients respectively. However, I'm not going into that technical details of this report, but I really encourage you to read our full reports where we have described our methodologies in producing these statistical results. So you can read them in details. So we have identified the risk factors. And as I have mentioned before, that risk factors increases the mental health risk. We find that being female is significantly associated with experiencing sadness, suicidal ideation, and poor mental health. We have seen it in bivariate analysis, but now we are seeing it in a more robust statistical analysis that this relationship still exists. And then we have identified that being bullied also significantly increases risk across all mental health outcomes. Similarly, screen time is associated with higher sadness and poorer mental health. So not all these variables are related to all three mental health outcomes. So for example, screen time is related to persistent sadness and poorer mental health, but not suicidal ideation. So I summarized them all together in this slide. So this means that students who reported that they had reported increased levels of screen time, also reported increased levels of experiencing mental health problems. So same goes for bullying. So students who reported that they became victim of bullying also reported that they had higher levels of experiencing mental health problems. And perceived unsafety at school. So like feeling unsafe at school increases sadness and suicidal ideation. Now the question becomes how did we measure unsafety at school? So school school unsafety, in terms of this survey questions, the survey asked the respondents during the past 30 days, how many days did you not go to school because you felt you would be unsafe at school or on your way to or from school? And they were given the options from 0 days to 6 days. So they are given like five options. So the higher day they were absent from school means that higher levels of school unsafety. So that was the perceived feeling of unsafety. And in terms of the screen time, students are asked on an average school day, how many hours do you spend in front of a TV, computer, smartphone, and or other electronic device, watching shows or videos, playing games, accessing the internet, or using social media? So it was like options are given from 1 hour to 5 hours, like there were 6 options given. So the higher, it's pretty easy to understand, like the higher hours they spend, the higher the levels of screen time. So screen time does not include the time they spend on the screen for learning purposes. So like for the educational purposes. And bullying, in terms of bullying, they were asked during the past 12 months, have you ever been bullied on school property? So so we try to be parsimonious in our modeling. So did not include cyberbullying. That's the reason, because we believe they're highly correlated. So if we include one, that already represents the other. Even though theoretically there might be difference, but we find a high correlation. So we needed to be parsimonious in our modeling technique. But we can claim the same thing for the cyberbullying as well. Okay, so now let me discuss about the protective factors. As I have mentioned, that protective factors reduce the likelihood of mental health problems. So protective factors include family connection, school connection, adequate sleep, physical activity, and academic performance, or GPA. So, and all of these significantly reduce mental health problems. And as I have mentioned, and I have noted here, not all mental health outcomes are related to all these variables, but at least they are related to one of the variables, meaning that they significantly reduce at least one of the mental health problems, as we have addressed in our analysis. So it's important to know what is the school connection. So they were asked the question, do you agree or disagree that you feel close to people at your school? So they were given the option from strongly agree to strongly disagree. So we reverse coded it so that the higher number means the higher levels of school connection. And then the family connection, they were asked, during your life, how often have you felt that you were able to talk to an adult in your family or another caring adult about your feelings? So like having the opportunity to talk to a family member about their feelings. So family connection and school connection and adequate sleep. So they were, in terms of the sleep, they were asked on average school night, how many hours of sleep do you get? And in terms of physical activity, they were asked during the past 7 days, how many days were you physically active for at least a total for a total of at least 60 minutes per day. And GPA, they are given the options from A grade to F grade, A, B, C, D, E, F. I think E and F, yeah. So these are the recent protective factors that we have identified in a sophisticated statistical modeling. So now the question is why we see the disparities that exist, particularly related to the gender disparity. The answer is we do not know. And it's been highly difficult for scholars to know from the empirical perspective. They have talked about many theoretical modeling that explain why the disparities exist, like women having like internalizing disorder, like when they feel they encounter problems, they internalize these problems, and when men like have these problems, they externalize it, like a non-prescription use of the drug. Okay, but why is that so? Like, is that biological? Is that social? Is that psychological? So there are many theoretical explanations given. So we are more interested not in the theoretical part, but in what we can know empirically. So may not be the root cause, but the interest was to see how can we reduce that disparity. So we have some interesting observation here. So as you can see in this graph, we see that the protective effects of academic performance, the better the GPA, the lower the mental health problems, right? Then we have further investigated the interaction effects. So as you can see, the top line representing female. So when their GPA is increasing, their mental health problems decreasing. However, for the male students, as you can see in the bottom line, it remains flat. As it goes up, it's still not decreasing, right? So the greater benefits female students are getting from doing better performance in school academically, right? So if we want to improve the problem of disparity, we need to reduce the disparity in what causes it like this. May not be a causal factor, but we know that improving academic performance for the female would improve their situation in terms of addressing mental health problems. And we have a few more interesting observations as well in terms of the lifestyle factors, like physical activity, sleep duration, and screen time. All they have some recommended levels. So, for example, physical activity 60 minutes per day equal to or more than 60 minutes, sleep duration 8 to 10 hours, and screen time less than two hours every day. And we see that in terms of physical activity as well, the first graph is representing this disparity between male and female students. So 42% male students reported that they experienced they meet the physical activity recommended level each day, compared to only 20% female. So some of the disparities can be explained by the disparities in these lifestyle factors. So we can provide some explanation of disparities. So, and same goes for Hispanic and non-Hispanic students. We see a significant difference between them in terms of physical activity. So Latinx students had significantly lower levels of physical activity compared to non-Latinx students. So, and in terms of the screen time, you see this difference between male and female. We didn't find significant difference between Latinx and non-Latinx students, but we see this disparity in screen time. So male students have significantly have higher levels of meeting this recommended level, which is less than 2 hours per day. Okay, so what we conclude is that we have observed high prevalence of mental health issues, notable disparities, and risk and protective factors that we have identified. So in terms of prevalence, as I have described, that we have observed 40% persistent sadness, 16% suicidal ideation, and 32% poor mental health. And we have seen that female students and those from Latinx background face disproportionately higher risk of mental health issues. And we have seen not only the disparities in mental health outcomes, but also in what causes it or what influences it, like physical activity, screen time, etc. And we have identified risk and protective factors that I have described. So the question becomes, what can we do about it? So I would respond to that is that the solution lies in the problems, right? So the problems are those risk factors, and the problems are the lack of meeting those lifestyle factors. So we need to really promote those protective factors and address those risk factors in order to solve these issues. And we'll have detailed policy discussions. Our team will do that later on. So now it's my pleasure to turn over to Tenille Black, who will present on the quality part of the research project.
Good morning. So with the research conducted by our quantitative team, we built a framework for our qualitative analysis by forming focus groups. Our goal was to discover those root causes that lead to those significant indicators that were mentioned in our quantitative analysis, and to hopefully uncover more significant indicators by including questions of household income or parental educational attainment in our analysis. So knowing that there were significant differences across demographics, we wanted to bring in voices from the LGBTQ community to identify mental health disparities within that community as well. We planned for 4 focus group sessions with 3 to 6 students to a group. Those 4 groups included 1 group that only controlled for age, only wanting high school students, 1 group of students that identified as being part of the LGBTQ+ community, and 1 group of all his Latinx students. To the right are our core questions mentioned in the beginning of our presentation. We developed those questions to spark discussions with students about various topics surrounding mental health, which I'll discuss later in this presentation. Knowing that sensitive and maybe triggering questions could come up during these discussions, we asked for the Department of Mental Health and District 7 to come in to sit in with us and our students as we discuss these topics. And we just wanted to ensure that the students knew that they were in a safe environment and that resources would be immediately available to them to utilize at any point during the discussion. So at the conclusion, well, let me state that after we did have the factors in place, we did go through the process of conducting the groups. We did have 5 group sessions where you see the breakdown here. 3 groups were students who were all in the Latinx descent. We had 2 groups that were control groups for age, and 1 unintentionally was an all-female group. 6 out of the 7 public school districts were represented, and there was a charter school representation as well. These participants were found thanks to Spartanburg Academic Movement's Out of School Time Collaborative and by Vida Salud out of the Upstate Family Resource Center in District 2. And as we attempted to form these focus groups with the LGBTQ+ community, we ran into some barriers concerning parental consent, and ultimately made the decision to not move forward with that focus group. The remaining groups, we did ask them to complete questionnaire before our discussion to get information about the household income, the parental educational attainment. And we asked if they had been diagnosed or treated for a mental health disorder in the past, and we asked them to self-report that. So due to students either not being aware of certain information or just choosing not to report, we weren't able to get data for further analysis on that part. But despite those limitations, we recorded about 208 minutes of conversation. Those conversations were coded by categories by our research team. The 5 categories you see here, the student perceptions, stress and challenges, coping mechanisms, resources and barriers, and the student-led recommendations. These 5 were our top level categories, and then we broke those down into even more specific codes. This QR code will take you to that full data documentation where you can see that breakdown from the top, second, and third levels. Today, we'll go through some of those high-level takeaways from these top-level categories, and we'll start with the student perceptions. And I'll wait till everybody gets that QR code. And if you're not able to get the QR code, it's also in the booklet as well and in the full page report. Starting with the qualitative findings of student perceptions. First, we asked students about how they define mental health and to share a positive or a negative experience concerning their mental health. Students express maintaining a positive attitude, self-image, or a good self-image, along with maintaining their emotions in stressful situations. And I forgot to mention the quotes underneath each takeaway is an actual quote from a student in one of our focus group sessions. Positive experiences included getting good grades in school. Negative experiences included grieving over loss of life due to catastrophic events like natural disasters or by suicide. One important note was when this question was presented to our Latinx students, many of those students couldn't provide an answer, or they felt that their mental health was not something that they should take into account, or they didn't think about on a regular basis. So they couldn't define what mental health was to them or in general. From there, we move to the discussion of the stress and challenges in their everyday lives and how that would cause their mental health to change. The biggest response were school expectations, ranging from the level of coursework, keeping up with grades, and being competitive with other students to be able to obtain scholarships, move on to college. Those thoughts and pressures concerning what their plans are after graduation fail not only with school expectations, but with parental and self-imposed expectations as well. Students talked about having strained relationships with parents or parents who constantly reminded them about college and maintaining grades and pursuing scholarships. And some students revealed that these pressures were self-imposed as well. Some mentioned they felt responsible for taking care of their families, their siblings, or finding work while in school or after graduation. Some of our students were dealing with the aftermath of Hurricane Helene at the time, and some were grieving from violence and suicide within our communities, and they found that to be challenging to deal with. All of our body image and how social media influence mental health and stress, about having a certain body type and gender roles, we talked about that mostly in our all-female group. And some of those expectations were relational, and we even talked about dating settings and how that could be stressful for them as well, and that was a conversation. Um, after talking about those challenges, we moved into ways that they cope or get through those challenges that disrupt their mental health. Students mentioned going to the gym, walking and playing in sports. Some turned to music, video games, and journaling. Most students utilize their social networks. They talk to their moms, their dads, siblings, cousins, friends, or reaching out to a teacher or a coach. Many express being able to cope when they have some type of strong and supportive social network. So we posed the question, where would you go if you needed resources outside of your social network? Do you know of resources in Spartanburg County where you live, where you can utilize these resources that are available concerning mental health? And the majority stated that they didn't know of any in the community. Guidance counselors were specifically mentioned by students in reference to resources in schools. One stated that other than managing IGPs, they didn't feel that they could reach out or talk to the guidance counselor concerning their mental health, to which other participants agreed or shared in that sentiment. On the flip side, many believe that even if they did know of a resource, there were barriers utilizing those services. Most males in our groups assume that they would be perceived as weak, and females are more encouraged to express their emotions and utilize those resources rather than males. Both the male and female students expressed a barrier of trust, opting to talk to someone in their age range or favoring peer support rather than speaking with adults. We asked students to, we also had students that said they didn't believe that their stress or challenge was severe enough to utilize those services that specialize in mental health, that they could handle it themselves, or they should be able to handle things themselves. And lastly, we wanted them to be a part of the process of creating solutions for our county. And we asked for their recommendations for schools and recommendations for the community. Student gave concrete recommendations, like implementing mental health days as excused absences, or beginning the conversation of mental health and introducing that terminology early in the schools and early childhood education between K-5 and first grade, so that the language and comfortability is instilled early rather than waiting for middle school or high school. They believe that schools and the community should increase conversations surrounding mental health awareness and be diligent in advocating for organizations who promote those resources specifically for the youth. And again, these are just some takeaways. As Bilal said, I would encourage you to view our full report to hear more of the conversations with our students. And we moved forward with the quantitative and the qualitative results, and asked, what policies can we put in place? What do we do with this data? And for that, I am happy to hand things over to Sarah Buckmaster, the Community Research Associate for Strategic Spartanburg, and she will explain that in more detail.
Don't mind me, I'm preparing.
Well, Midas does that. Good morning, everyone. I'm Sarah. I'm the Community Research Associate. And today I have the pleasure of being able to share policy and practice implications of our research with you. And I'm the only thing standing between you and the panel discussion, which I know is what everyone really is here for. So I'll try to keep it brief.
Here's what you said.
And you can quote me on that. So we know that legislation at the state, county, and municipal level has the power to impact youth behavioral and mental health outcomes. So public policy about youth behavioral and mental health can range from government-based interventions, school-based interventions, to community and family-based interventions. And so what I'm going to do today is highlight some evidence-based best practices that are known to reduce adverse mental and behavioral health outcomes. And so while these are organized into the 3 different categories, this doesn't mean that these categories don't overlap and intersect. So it will become apparent after examining each intervention how critical cross-sector collaboration really is for when we're thinking about how to improve youth mental and behavioral health outcomes in our county. So the interventions that I'll share with you guys today on the government side standpoint is enhancing screening opportunities and then funding multi-tiered systems of support, which I'll just refer to as MTSS. In schools, there are 2 programs that I'll show you, modeled by the CDC, that are known to reduce negative outcomes in mental and behavioral health and promote student and faculty well-being. And then in the community, we'll talk about the importance of maternal mental well-being, how we can provide culturally responsive interventions, and then how we can educate communities and families about what eating disorders look like among our students. So the easiest way that we can enhance screening opportunities here in Spartanburg is to capitalize on opportunities that already exist. One of which is the YRBS. So the survey data that we've been analyzing for you today. This survey has been conducted in South Carolina in high schools every other year since 1991, and then in middle schools every other year since 2005. And Spartanburg County is the only site of YRBS data collection in South Carolina, and so the CDC does not make statewide projections for South Carolina. Most recently, the YRBS was administered in partnership with Connect Spartanburg and the Spartanburg Regional Foundation, and they administered surveys across districts 1, 2, 3, and 7, like Bilal shared with you earlier. And so because we have facilitated the YRBS through partnerships locally before, we are positioned in a unique way to institutionalize this screening tool at the local level to ensure that we can continuously screen and monitor youth behavioral and mental health outcomes, even in a climate of data uncertainty. So really briefly, this is just a map of where the YRBS occurs. States in dark blue have representative state results. States in light blue had districts participate but don't have representative state results. And then states in white chose to not participate at all. You can see Spartanburg County is not positioned correctly, but it is there. And so we're the only site in South Carolina. But why does this matter, institutionalizing the YRBS specifically in Spartanburg? It's critical just because of the data climate we're in. Data sovereignty is at risk right now from a national standpoint. It's not a political statement, it's a statement of reality. And so if Spartanburg was able to institutionalize the YRBS and expand it to each school district, we would be able to keep consistent measures of youth behavioral and mental health outcomes over time that aren't subject to political wills, while also engaging in a best practice that is known to mitigate poor mental and behavioral health outcomes. So what does this look like? Gathering stakeholders to develop a comprehensive and strategic plan, and then also to fund that plan and its administration biannually. With this opportunity, we could tailor additional survey questions to fit the local context of Spartanburg that we've identified and shared with you today, and dig deeper into the identified disparities. And like I said, this would allow us to monitor changes over time. The South Carolina's Mental Health in Schools Act is another way that we can enhance screening opportunities. Legislation in several states mandates screening across all public schools, and that's an activity funded by the states. Across the nation, these screening tools look different, but what is clear is that screening is important for prioritizing the well-being of students, specifically prioritizing mental and behavioral health outcomes. Take a sip of water. So specifically in South Carolina, earlier this year in January, this act was introduced in the House. It has since been deferred to the Committee on Education and is going through the long and contentious legislative process. But if the Mental Health in Schools Act was to pass in South Carolina, this act would mandate annual mental and behavioral health screenings in public schools for students in 6th through 12th grade. This would identify risks and adverse outcomes, which would be addressed through the provision of resources and referrals by the school. So this is just something to keep your eye on from a community perspective, as well as something to keep your eye on to advocate for or lobby for from an institutional perspective. But what comes after we screen the students? We've screened the students for mental and behavioral health risks, but how can our local governments further support students and promote prosperous outcomes? We can fund MTSS, or the multi-tiered systems of support within schools. It's a widely known, accepted, and praised model for the ways that it integrates strict academic education with social, emotional, and behavioral learning. So this is the Power Schools model of MTSS. And what makes MTSS such a good model? Like, why is this the current standard? It's a framework and not a program that can be adapted within school districts, but all the frameworks consist of the same basics, which are tiered supports and interventions, and a focus on the overlap between academic, behavioral, social, and emotional needs. So all of these are interconnected and must be addressed holistically, so the MTSS model focuses on the child as the whole and focuses on preventative and proactive practices. So each tier has different sets of curriculum that goes along with it. The bottom tier is universal. All students would fall into this category, and based on need, behaviorally, academically, emotionally, students would be filtered into tier 2 and tier 3 for targeted supports. This allows educators to make well-informed and data-driven decisions in the classroom in real time in connection to behavior management, social and emotional learning, student-teacher engagement strategies. And there's also another model of MTSS that I really like that's emerged in recent years. I like this model because it allows us to understand our students on a continuum or an array or of a spectrum of possible mental, behavioral, and emotional health outcomes. So this diamond model not only recognizes and provides targeted support to students at risk for poor mental and behavioral health outcomes, but it also includes enrichment and extensions for students to accelerate social, emotional, behavioral, and academic learning. And so this would be to challenge students that fall in that tier 1. The first model is more widely used in practice, but if we're thinking about accessibility in Spartanburg and making all levels of learning accessible, this is a good model, I think, for our county to look into. So South Carolina has MTSS legislation in place. The framework was most recently updated in 2024, but it emphasizes only universal literacy screenings for kindergarten and first grade students. It excludes social and emotional learning and just leaves that up to districts to include if they feel it's important. So what this means in actuality is that students in South Carolina are screened for reading challenges and not for social, emotional, and behavioral ones. We know from the literature that screening students in K-5 and first grade is the perfect time to begin preventative habits and behaviors that mitigate poor mental health outcomes in the future. But currently, South Carolina's MTSS framework does not include social, emotional, and behavioral learning. So if we think about what we can do in schools, and I'll go through these a little bit quickly because you can dive deeper into them in the full report and the executive summaries that you have. But the CDC has two different programs that are evidence-based models for implementing social, emotional, and behavioral learning across all grade levels. This is the CDC's What Works in Schools program, and it's specifically designed to promote adolescent health and well-being across these 5 different pillars, which are quality health education, sexual health education, quality health services, sexual health services, and safe and supportive schools. These pillars are all intersectional, and they consider the varying dimensions of student health and work together to create an environment in schools that's not just about strictly academic learning. Out of the CDC's What Works in Schools program is this really awesome guide for schools and district leaders. It is similar to MTSS in that it promotes academic and social, emotional, and behavioral learning, but this is less of a strict tiered framework. It emphasizes student mental health literacy, promoting mindfulness, enhancing connections between the community, families, and school, providing psychological training and resources to staff within schools, and also considering staff well-being as an important pillar of how we support our students. The CDC's Healthy Schools program is very similar. It's considering students' physical health and well-being as essential to their overall well-being as a person. Schools have direct contact with our youth for more than 6 hours a day for almost 13 years of their life. So that's a really long time that schools are interacting with students and contributing to their intellectual development. And so this program is specifically designed to emphasize healthier nutrition options, as well as nutritional education, physical activity programs, and promoting physical well-being within schools. So now if we kind of zoom in even further, we've thought about government, we've thought about schools. What can we do for families and the community? We know that promoting maternal well-being from a family and community standpoint has proven really important to fostering an environment where childhood and youth well-being is promoted. And so the Policy Center for Maternal Mental Health and Well-being states that 1 in 5 expecting and postpartum mothers will suffer a mental health disorder. And so this policy center provides model legislation for other organizations to look at how we can promote maternal mental health from a legislative standpoint. They have screening tools available to nonprofit organizations, and then they also have a program that helps link uninsured moms to care for maternal mental health. And so locally in Spartanburg, if we're thinking about promoting maternal mental health, I think organizations like Birth Matters and Live Healthy Spartanburg could be really critical to leading this effort. Community programs for students and family can also provide culturally responsive interventions for youth experiencing mental health concerns. The Journal of Contemporary School Psychology, which is this lovely little picture on the right, suggests that culturally responsive programming considers gender, sexuality, religion, race, ethnicity, language, and the age of participants within a program. And then it further suggests that culturally responsive programming looks like building cultural self-awareness. I think that there's something covered there on that second one, but developing an understanding of the youth's background, providing individualized treatment, utilizing culturally relevant materials, building on cultural strengths, which is my favorite one if we think about asset-based development, and then encouraging identity-affirming activities. And then lastly, as Bilal shared earlier, there are a range of protective and risk factors that students experience that are contributing to stress and challenges. And so each of those have different interventions that we could think of, but I just wanted to pull out one specifically and think about how we could target body image and female students persistent sadness related to body image. Okay, we're good. So one example of how we can do that is to have a specific intervention addressing education around eating disorders. Statistically, we know that dieting as a teenager increases the risk of developing eating disorders and risky behaviors. And diet culture and body image was something discussed in the focus group with all female students. So I looked to the Butterfly Organization, which is an Australian organization for eating disorder awareness, and they ran a Body Kind youth survey. They then turned this survey into a media campaign, sharing their stories to end stigma, which is what you see on the screen here. And when you go to their webpage, you can actually hover over each and hear the stories of how the hashtag is an eating disorder looks like me. And so this Butterfly organization has a bunch of other really awesome tools and program models for promoting education about eating disorders. And I think any of these initiatives could serve as models for eating disorder awareness and education in Spartanburg. But that is all from me. Further initiatives and evidence-based practices will be highlighted in our upcoming policy brief. So be on the lookout for that. But it is my pleasure to turn things back over to Dr. Midas Hampton so that he can introduce our esteemed panelists.
Hello again. We've heard a lot today. And so one of the things we really wanted to do was to move it out of this nebulous space into a more concrete, hear the people who you see in front of you who are working on this, who understand it at a contextual level, at a practical level. And what we're going to do is move into a panel. And then from the panel, we'll open it up and my full team will come up and we'll have a Q&A session for you all and online for the panel as well as the team. I'm going to call up the panelists and ask that they come up when they are called. I would be here all day if I tried to read you their entire bios. You have a little leaflet that you can peruse and know who's on the panel. But maybe next time we'll spend 2 hours me just reading their bios and all of the lovely things that they've accomplished in their career. So first up to the stage, Mr. Collenbauer, Student and Staff Wellbeing Coordinator for District 7. Please give him a hand as he rises. And rounding applause to the newly minted Dr. Lori Thornton, who are coming up. She's from the Department of Regenesis Healthcare. She's the Director of Behavioral Health. My board member, who is the executive director of Spartanburg Regional Foundation, Polly Edwards Paget. And then the incomparable, you know him, and if you don't, I don't know where you've been. The rock is big for you. Tom Barnett, who is the chair of the Behavioral Health Task Force. You all are coming with me. Perfect. Water, anyone? All right. I'm a gracious host. Make sure everyone is fine. We've heard a lot today from a quantitative perspective, qualitative perspective, and for us at Strategic Spartanburg, it's really important to have both. It tells a complete story, more so than just having one or the other, which is not to say that doing that is wrong, but for us, we need a complete story because it's not about admiring what the issues are. It's about how do we effectively come together to address things, right? And so as you saw, we in our policy and practice portion talked about the different kind of levels. Everyone has a fight in this work. Everyone has a place in the space. So we talked about our government, school level things, community, homes and families. So I want to ask, I'm going to start off at the highest level, right? You think about government, think about philanthropy, and the work that is already happening and the work that could happen. So my first question, Polly, is for you. What role can government, local government, and philanthropic leaders play in shaping public narratives that move Spartanburg away from crisis-based mental health responses towards a culture of prevention, openness, and youth mental and behavioral health?
Thank you, Midas. What a very complicated question. Right. A great one.
We cut straight to the heart of it.
So I think it's really important. First of all, I want to say thank you to Strategic Spartanburg for this beautiful report. And I think that is something that's important for philanthropy as well as other governmental entities to have an entity in their community that is helping us collect data, understand the narrative, so that we can make informed decisions that are driven in what the data is telling us. And so I think that's a critical role that we play in making sure that continues to happen in our community. But it also, for philanthropy, and I know we have several funders here in the room, United Way, County Foundation, Mary Black Foundation. It's really important for us to be able to be a neutral convener in the space. When you're dealing with crisis, like schools, clinical care are dealing with, we have the ability to go and look at the ecosystem of everything that's involved with complex issues. For our ability to convene those groups and have those, having good data like we've got here with Strategic Spartanburg, being able to have those conversations. Tom does a great job with this with Behavioral Health Task Force, of being able to look at that ecosystem and identify where are we fragmented, what are the continuums of care, where are we under-resourced and inadequately resourcing areas where the data is showing that a disparity may exist. And then how do we bring that and look at that from a perspective of not only how are we monetarily going to resource this, but what are our non-monetary resources? Whether that's advocating and bringing light like today and letting people know about what's happening, but also really thinking through what are those innovations that we maybe are not thinking about. Sarah did a beautiful job, I was looking for Sarah, talking about what are those evidence-based strategies? What are some of those innovations that maybe we haven't explored before? The core of all of that, whether it's governmental entities or philanthropy, is that we're listening to our community and ensuring whatever the strategies are that we define or think that might be innovative and next and new, that we're listening to make sure it adheres to our community values. And that's critically important. And, you know, we started the collective, a plan for behavioral mental health as a collective look from mothers all the way through adults. And really bringing the community together to say, what are our priorities? What are we doing really well? And I think one of the biggest questions in that is, and is it fully staffed at the capacity of the need of the community? That is critically important. But it also allowed us to say, where are we fragmented? How can we build those better continuums to work with each other? Sometimes we get in our own silos. And so how do we make sure that's happening? And then where are those innovations and investments needed? And the investments are, it's a lot. But as I say to folks all the time, I wish I found the money tree, but we have not found it yet. Dollars are limited, resources are limited. And so how do we bring together public and private dollars together to make sure that we're working together around the investments that we see and that we know and we hear are needed?
One thing that struck me was this idea of innovation, right? And I just want to double tap into that with you for a second. There's oftentimes with funders, there's a barrier, it's a balance. I wouldn't say barrier, a balance between funding things that are pilots and innovative, and then funding things that you've been funding for years that may not be garnering the results we want to see, but it's doing really good work, right? How do you strike that balance?
That's a great question. You know, we say all the time that when you're looking at these big plans, like we're doing currently at the foundation in partnership with the joint funders, it's the crisis is not going away, it's still here. So we have to keep funding the crisis and the things that we know are needed right now, with the ability to not look at sometimes the existing dollars, but where are there new dollars and new opportunities for things that we know are needed? For some of the crisis piece, it's gonna be, is it fully resourced at the level it should be? Because there could be additional dollars and leveraging needed to get to the capacity we need. We're a growing community. Alan tells us that all the time. We all know this. We're growing very quickly. And so making sure that we can help our crisis meet the needs as we grow. And then looking for new dollars and new ways of thinking through funding. We are currently working on a plan, and the plan we're working on talks about the braided funding stream. I think innovation funding is important for philanthropy to get things started with new dollars, but at the same time, thinking through long-term, are these going to be sustainable with public funds in the future? And that's where some of the advocacy lens comes in for philanthropy as well, is, if we can test this innovation, if we find it's working, how will it be sustained through public dollars and through other dollars long-term? You cannot ever turn. The crisis work is going to continue. And as we grow, it's going to become higher levels. We have to make sure that work's happening. The ultimate goal with innovation is that people are getting healthier over time in our community because of the wonderful work you talked about with NTSS, healthy schools, mothers. You're also hoping that over time, those proactive approaches is we're gonna have less folks in crisis, but you've got to keep that balance and making sure that you're always looking at it, which goes back to the importance of organizations like Strategic Spartanburg, who are looking at data and helping us understand where does that balance need to be struck.
Absolutely. Colin, the next question is for you. We talked about the work of the innovation work, right? The plan that we have to build, the things that we have to think about for the future. But right now, our students are here. Right now, they're still going to school. Right now, they're still seeing these outcomes, right? And so my question is, given the protective factors that we talked about, like school safety, physical activity, family connectedness, what strategies do you feel schools and communities can implement to dismantle stigmas around youth mental and behavioral health, particularly for males and students of color, so that early intervention becomes normalized and accessible?
I'm going to take a feather out of Polly's book. Whoever crafted these questions, it's wonderful. If we have 3 hours, we might be able to solve this, right? But it's a heavy question, okay? I will say this. Back to Polly's point, when it comes to understanding research and doing things, with science and ensuring, say the funding, even though we might have the programs, or even though there might be the interventions, the preventions or the actual interventions in a crisis, or even the postvention, unfortunately, that we've had to do, we've had several deaths, not only of students, but also faculty members. If we do not do those programs with fidelity, if we're actually not doing it correctly. And there's a wonderful program called the TOPS program, Teen Outreach Program. And if we do that, which is a social emotional learning curriculum, is that when we do that with fidelity, then we do see better outcomes. But I think the reality is that when you're talking about, I'm so glad, Sarah, you talked about MTSS, the multi-tier system of support. Absolutely, it's rooted within research, by positive behavior intervention to support. It's an interconnected framework where you're looking at academics, also mental health, behavioral health, and all these other aspects. Is that many times though, is that in education, we just want to focus on say, I'm just a teacher. I just want to teach the subject. Why do I need to look at the other aspects of our children? Well, that's not our reality. We're coming in with very much systemic issues within our community. We have something called ALICE, Asset Limited Income Constrained Employed. We have high poverty rates. We have actually increases in worry and mental health and depressions and all these things outlined in Strategic Spartanburg. But also we're seeing high cases of suicidal ideation. And so I can speak specifically for District 7, is that we unfortunately, or very fortunately, they did not die, but we've had recent aborted suicides where people actually not only had thoughts and ideas, but also because of sadness and lack of the protective factors. And I would actually say is that if we're not actually teaching, I would say even 4K or even kindergarten, actual techniques of what social emotional learning is. I just want to go through that really quick because I think many times we use SEL, but really what is it? It's really 5 competencies, all right? And those competencies are self-awareness, understanding about our own emotions. Can we teach our children when we become upset or become worried, what is happening not only in our brains, what's happening in our body, what's happening around us? How does that affect it? So that's so self-awareness. Self-management, when we have emotions and things, how do we manage that? How do we go through these different layers and zones? And there's very easy ways that teachers can do this. That's a tier 1 intervention. Again, it's changing this mindset that if we're going to get to the academics and to the prefrontal cortex of our brain and the neuroscience, we're going to have to basically deal with the basics of our, what's going on in our bodies. And so then you're looking at social awareness. How do we interact? How are we able to show empathy? If someone is actually hurting and we know they're actually having difficulties and they're saying, hey, I'm thinking about hurting myself, instead of texting saying, well, go ahead, kill yourself, why don't we actually take that actually happens, saying this is very common. So instead of doing that, actually having the confidence and saying, I need to guide you to someone that I trust. And what was very striking was saying is that from the students in these focus groups, saying that I don't think I can go to a person in my school that I trust. So now we're talking about climate and culture. What are we doing within our schools specifically, not just as a district, but within our schools and our communities, that is creating that ability for students to feel connected, feeling that they actually have people and actually not just family members, but also community members? What are we doing within our classrooms and our hallways? And we have certain schools. I'll just brag on Carver Middle School. My daughter goes, she's a 7th grader there. Specifically, I'll brag because I know when class changes, you're saying that's the highest time of bullying. That's the highest time where, kids can actually get into arguments. But it's an expectation that that the teachers and custodians and support staff, administrators are physically present in the hallways. That is critical. And then also if you are able to prevent bullying issues, or you're able to see when kids are having difficulties and you have relationships with students, not just academically, but you genuinely care about that child. Well, now you're also learning your social emotional learning competencies. And then lastly, I would just want to say is that if we're really going to be able to do this, is that we have stigma. And what we're showing is that many young men, especially men of color, there is a gigantic stigma when it comes to mental health and actually accessing services. It's considered weak. It's considered that you can't take care of your own issues. It's the inability to be able to recognize is that possibly I might actually be degrading and something's going on emotionally, but I do not have the courage to be able to stand up and get help because I'll be looked at as being, a sissy or a wuss. And that is not how men are supposed to actually behave. And so we have these issues. And so I'll be very, very excited to say because of Keith and his support, OST Collaborative, having the TOPS program and working with students at Daniel Morgan, with special needs, looking at the Bucky Early College. Also, you have athletics and other places utilizing some of those things. You're beginning to actually see students being able to be more comfortable and having these conversations. And they're talking about mental health issues. They're talking about give and take. They're practicing these competencies. But if we don't normalize this and we don't have, I would say, everyone and all educators being responsible and understanding that we all need to be trained with the not only protective factors, we need to understand warning signs. There are many warning signs and they're very simple to be taught. We also need to ask ourselves, why are we not asking the questions? If a person is truly hurting and we think they actually might be killing themselves or want to kill themselves, it's okay to ask the question, have you thought about killing yourself? Have you thought about suicide? That needs to be our common. That needs to be very normalized. And what's happening is people want to shy away from that. They think that if we ask, if you want to hurt yourself, that somehow that it gives this idea or permission. What it does is it actually creates connection. It creates ability of safety. It shows that I care about you. That's what we need to be normalizing. And that's not just a District 7. This is a statewide, I would say, and nationally issue that we have to have. Let me just close with this, is that when you're thinking about, I think the biggest thing that we have to do is also expand not only the protective factors that you talked about with family connections, but we also have to understand is that there are many beautiful differences within our community and who we are. And the way that we express ourselves and the backgrounds that we come from, that is called cultural humility, cultural understanding. And when we recognize is that there actually are beautiful differences And being able to actually highlight that. And when educators are not fearful of saying, hey, let's study different, maybe religions, or let's study different countries, let's study about different backgrounds. That actually is creating inclusivity, is creating people feeling safer in their schools, it actually reduces bullying, it actually increases, academic success, it creates emotional intelligence. So why are we not having broader conversations about the interesting things about each other? And I think that, again, not getting political, but I think those are really, really things that our young men are really not feeling that it's okay to share their feelings. It's not okay, you know what I'm saying, to be able to not be a football player or in sports. And so I think we have major problems. And it also comes out, we talk about this, externalized behaviors. You'll see more externalized behaviors coming out if it's not addressed. And we don't actually talk about really what the root cause are, then we're going to continue to be down this pathway.
Yeah.
I'm sorry, didn't mean to go.
No,
on.
I think I was engrossed. I was like leaning in.
Passionate.
Yeah, no,
I'll give
I
you
love
some
it.
of my time, just want to keep
No,
going.
no, I love passion. You mentioned something that struck with me when we were doing the research, because I think we were in the same room. Cullen was there to support, as we did focus groups. And when the students started to talk about like school counselors, and how their functionality with them only revolves around, what is it called? The
Integrate.
IGPs. What are they gonna do after high school? And that's the only time that they had any meaningful interaction with them. And it's like, well, you want me to come to you in my moment of distress, when the only time you and I have ever spoken was about what I'm doing next? Like, that was a shock to me, because I didn't know that that was the case. You also spoke about like just,
I will say this just please understand, that's a generalization.
yes.
But because
It
that's
really
not
is.
all the cases.
No,
Right?
it is
I
not.
mean, because there are very deep connections that some people are making.
100%.
But it does accentuate that this individual truly felt there was no connection
But it
with
also,
that, their school counselor.
but it also shows that, and I don't know about you, negative news travels faster than good news.
Yes.
And so students are speaking to each other, when it's a great relationship, they're not like, oh my God, this is a great relationship, you should tap in and talk to Colin. They're like, don't go talk to them.
Nope. Yeah.
Right, and so that's what I mean. So not to be general. Thank you for that.
No, you're fine.
Another big piece was around this, biological aspect of it. And for me, I think about the clinical side of things.
Okay.
And so we've talked about high-level government interventions. We talked about the schools. There's a clinical side to this as well. And so, Laura, I would love to pull you in to the conversation with a question just around clinical practice. So as you go through your work, what are some of the most urgent service gaps you're seeing among youth in Spartanburg County? And how might cross-sector collaboration help fill them?
Great question. First of all, in its report, it's reflected in the report. I think that having culturally competent and sensitive care for our Latinx students is really important, as well as our LGBTQ plus students. I think that there's much growth that we can have in that area. And so that's one thing that I see as a gap in care and in the clinical. Also, particularly with our rural areas, we need to have accessible and affordable care. And this includes transportation. This includes brick and mortar in our areas. I think our schools are doing a great job trying to add the clinical aspect, but I think we have a lot of support that is still needed in our rural areas. Telehealth is an option as well. And, that's back and forth with our legislative and with our boards, but we need to continue to look at that as well as an option. Another area that I see, and I've talked to my friend Ken Huff a lot at the cafe. He's done a lot of great work over the past few years, but support and education for our parents. A part of the report is that 40% of our parents are stressed because of their children's mental health. And so I think that some barriers that we have there, and that this is a clinical area, is that sometimes our parents struggle with their own mental health needs. They don't know where to turn to. And I think we've started a great conversation and a great support through cafe. But that funding is going to come to an end, and Medicaid does not cover that kind of support. And so I think our community has a great opportunity to come around Ken and the staff that he's been working with over the past 4 or 5 years. So that does not end, because the kids need the support of their peers. They need to have that stigma decrease. They need their own mental health literacy education, but they need the support of their parents, and their parents cannot do that if they do not have professionals in our community who are passionate about helping them learn how to do that. And so I think that is a huge clinical opportunity that our leaders here and our stakeholders here today can gather around, and how can we continue that conversation? Because if we don't, if we think about our children with multi-leg support, our schools, home, peers, and themselves, that school is not going to be balanced. So I think that's a huge opportunity that we have. I think also my committee members I've been with, they know that a huge support, a huge passion that I have from my own study is that we have to continue to think about how are we going to support our teachers. They are equally stressed by the mental health needs that they're seeing. And I think our schools are doing a great job in our state and helping them as well. But we have to find ways to help support increasing the mental health literacy of our teachers. And they're with the students more hours than anybody else is during the day. And so we have to continue that conversation. We have a lot of youth in our community who are suffering with severe mental health, and that's hard to think about, but there's a lot of really hard issues that they're dealing with that no fault of their own. They've inherited biologically some predisposition to some really heavy mental health issues. We have some great, I think of CCBH, that's a great partner for us in terms of inpatient, but we don't have a good infrastructure when those kids come out of that acute care. We do not have intensive mental health, to support the kids as they're coming out. And a part of that desert climate that we have is with psychiatry. We do have some great psychiatrists. I work with a couple. They're doing everything they can, but when we think about the poverty that we have in Spartanburg and how many of our students rely on Medicaid, we need to look for ways to increase to attract psychiatrists to our area, and then also to sustain that care. I think that's critical.
Yeah. What gets me a lot in our work, so when we're doing research, a lot of the times analysis requires a level of density. Density means like a number of the population size has to be at a certain level so that we can, with any kind of accuracy, tell you A or B. I can tell you A plus or minus 30%, and you're like, well, that's not going to help me at all, Midas. But one of the biggest barriers in this work, and you touched on this, is like geography, rural populations, like rural spaces, right? And I think about just distance, right? When you think about like solitude and like this idea of loneliness, is one of the big things out of the literature that has come up, and it's not something that everyone's grappling with it and trying to figure out how to address it. And so we're not alone in that fight. But when you think about full community, for you and Tom, to talk a little bit about the work and the strategies that the Behavioral Health Task Force is currently implementing or has been implementing to reduce mental health disparities. That's one, but because you're Tom, I'm going to give you 2 questions. Right? So that's half of the question. The other half is, how are the findings from Strategic Spartanburg's report, right? How is it going to be supportive in the ongoing initiatives that you have? How can you use the things that we've found in the work that you're already doing?
First of all, let me say that it's very exciting to see the maturation of what used to be the community indicators or critical indicators of 25 years ago, becoming a far more usable working document. I've been in awe of the reports that you guys put out today. And that becomes the vehicle that gives credibility to strategies that we may or may not design. The Behavioral Health Task Force, and without going into its evolution, is, I guess, about 13 years old now. There are something in excess of 180 professionals that are involved in it. It meets quarterly. It is a think tank. It is not a policy making. It is not an administrator. Its object is to get people in the room and think, what ideas does this community need from your perspective? And once an idea percolates from the group, it becomes, we develop an ad hoc committee. That ad hoc committee is assigned to design a plan that is self-sustaining. We do not want, one of the first things I learned from the people in the county is, please don't get us a 3-year grant that as soon as 3 years is up, we've got to dismiss the process. No, it has to be sustaining. And above all, we found that it has to find what I always called a garage to park it in. It needed to be in somebody's organization so that it had a built-in administrative tool. It is not uniquely focused on youth. There are a lot of the things that come out of the Behavioral Health Task Force that address other populations. Although it is very hard to say that there are some that are totally unique to adults, but some of the things that we're working with in one of the sub-coalitions called the Recovery Coalition, probably have a more adult-oriented concept. To give a couple of examples and maybe to build on the suicidal ideation, one of the concerns that existed at some time ago was the protocol for youth with suicidal ideation going into the emergency room, the protocols that would then become baggage when they went back to the school, and the lack of communication between the ED and the schools. Both because of the protocols, they couldn't always tell anything. We discovered a form that was designed by the University of Michigan. And that is a fabulous process so that the students are going back without that much baggage. And it is, I mean, it's self-sustaining now. It does not need the Behavioral Health Task Force to discuss. I think the most significant one, as far as this community is concerned, was ACEs training. And the Behavioral Health Task Force underwrote the first year of all 7 school districts implementing ACEs training. Each district got to design it how they wanted. Some picked administrators, some picked classroom teachers. It is a process that, as I said, we underwrote. All 7 districts now own it. It has migrated into even larger questions, resilience. It is pervasive through the educational system. It is not exclusive to teachers and administrators. It goes to people in the kitchen. It goes to people, the bus drivers, janitors. They are aware of this process. It is owned exclusively by that. We started to develop a trauma-informed community. And we created something that has, and I say we, it's really the people that implemented it, not the task force. Created something that is an invaluable asset to this community. In my perspective, and I think most people would agree, it really became the foundation for what became the Spartanburg academic movement and became Movement 2030, because it put together the community assets that can address youth questions. There are a host of other examples. I have to look at my own list. Yes, years ago, we were approached to develop an eating disorders curriculum, which is now owned by VCOM. And they use it with their medical students and they bring it into the community. Duke Endowment came to the Behavioral Health Task Force about 10 years ago, said we want to fund something. And we held them off for about 3 years until we had what we thought was worthy of the amount of money they wanted to commit, which is significant. And we built a telepsychiatry model that Duke underwrote for the first 3 years and the Spartanburg Regional now owns. It's embedded in the practices. It means that the physicians can get consultation. Are they prescribing the right medicine? Are they diagnosing correctly? And people can go in there and have a telepsychiatric, someone they can talk to without necessarily the stigma of going to a psychiatrist's office. because that in and of itself can become an intimidating factor. We know our society is still not ready to accept the fact that mental illness and physical illness are on the same spectrum. They are on the same continuum, and we need to keep working in that area. The cafe evolved to a certain extent from the Eubank Center, which is a peer-dominated, or peer-supporting system of folks that are in distress. It is conveniently located, like the cafe, halfway between the ED and the Department of Mental Health. It's a place where individuals can go and talk to someone who's been there, done that. And one of the things we discovered in our society is that the best influence on people that are having mental and behavioral health issues is someone who's been there before. The easiest illustration are veterans. It is much easier for a veteran to be a wise counsel to another veteran than for somebody with a lot of degrees, but no common experience. So out of all this, I mean, this is how the behavioral health task force operates. And it meets quarterly. Half the people are, well, not half the people, half of the audience, we never know how many are gonna be at each meeting, are in person and half are via Zoom. The feedback is extraordinary. But I want to use just one illustration just to end of this question. Because the Spartanburg academic movement is going to have a day in the fall for guidance counselors. And all the guidance counselors in Spartanburg County are going to be in a program that they're developing an extensive curriculum. 30 years ago, I mean, 33 years ago, Spartanburg County Foundation underwrote the cost, Jim Barrett at that point, underwrote the cost of a guidance counselor retreat, and 78 guidance counselors from all 7 districts and the Spartanburg Day School went to Lake Junaluska for 3 days and 2 nights. And with the help of USC Upstate, we organized a terrific agenda of professionals, because the big concern was guidance counselors were becoming clerks and doing the work of principals. Well, when they decided to do this, I said to the committee, let me share you my notes, and I just don't throw enough things away. I sure enough found the agenda and the folks that we used 35 years ago, and the curriculum that we designed for that. And the astounding thing is the same questions that concern guidance counselors today were the items on the agenda 30 years ago. Mm-hmm. We can, the challenge is never ending. The issues may be slightly different, but the work is there. So are we building a trauma-informed community? I think we are. I think Spartanburg is a unique community in that it avoids a lot of the silos that are an inhibiting factor in other communities. And I am in constant awe, and I'm not a professional in mental health, behavioral health. I'm sort of a process person. I am in awe, and I used to be a guidance counselor, so I have some credibility in that. But I am in awe of the willingness of the folks in this field to see that their best work is done cooperatively. And that's why being on this panel is for me, an honor and a privilege.
Absolutely. Well, thank you all for being here. I have one last question before we open it up to Q&A from the audience in person and online. If they have any questions online, feel free to drop them in the chat. Last question. As researchers, we have all done, or most of us in my staff have done peer-reviewed research, double-blind peer review. And so in this double-blind peer review process, you submit your thoughts, beliefs, ideas to a group of people you will never meet to criticize you heavily. And there's always reviewer number 3, who has the worst things to say about the things you worked so hard for. So in that same vein, we ask our panelists to critique us. From your perspective, what critical insights or barriers do you believe we're missing from our work or underemphasized in this report that the community needs to fully understand to support Spartanburg youth?
Since I was last before, let me be first, and then I keep my mouth shut the rest of the way. I am pretty much in awe of the volume of data, and it takes time to absorb all of that. As a process person, I'm not as obsessed with the data. If it's 12% or 18% on an issue, it's a problem in either number. I think the challenge is to take this data and find a way to prioritize where we expend our efforts and our dollars. And Polly was exactly right at the beginning. I think we know that it is going to be a very difficult time frame over the next few years securing funds. We know that things are gonna happen out of Washington that are different. We know that as we get smarter, our demand and our needs gonna get greater. So we owe that to each other to make sure that we're all working off the same page. And that's where this data and your input and your interpretation of the data is so valuable.
In the behavioral mental health plan, we've been doing this for the last year. Thriving youth and families is a priority, and you hit the nail on the head for MTSS, screening, stigma campaigns, all of those things are showing up in our plan, as well as the critical importance of the cafe, in-bed capacity for the healthcare system, all of those things. But I have to put on my Connect hat, and I'm kind of laughing that Keith left, oh no, putting on my Connect hat, that one of the things we look at in the adolescent health world that is so critically important that we can't forget, and sometimes it seems so simplistic, but as a mother of a 13 and a 15-year-old, it's so difficult. Young people have to have a sense of belonging. That is critically important. Earlier we talked about kindergarten. Some of those skills that Colin,
There you
Keith, you're like you left the worst time, but it was.
go. How dare you, Keith?
Yeah. Hold out for a raise.
That's right. Colin talked about kindergarten, empathy skills is what prevents bullying.
Yeah.
Empathy skills is what allows kids to have a sense of belonging with each other. And to feel included. And I think some of that is our responsiveness of how we're providing spaces for a sense of belonging for LGBTQI youth, for Latinx youth, for young men of color, for girls. What is that looking like? And sometimes we can create things, and young people, if they're not mentally healthy, they don't want to participate. And so finding ways and thinking through with them, not creating for them, but with them, how can we help you find that sense of belonging?
Absolutely. Lori?
I think a question I have is, how we do have the task force, but how are we going to continue to collaborate so that we continue the conversation in a meaningful way, moving the needle, not being siloed? I think that's a big thing. And also with the data, how are you going to continue to gather data and then also share that data as we're moving through this process, so we know where we need to be moving stronger and more intentionally.
Absolutely. Colin?
So, I know, just really quick, I know. Got 2 seconds.
I saw the passion flaring up when he was just wall.
He's taking a deep breath.
No, so in my experience, a lot of the mental health concerns that I'm seeing with students and are very similar to the wellness and the kind of mental instability that we have also with our adults. You cannot take your background, we talk about ACEs, and maybe even extended ACEs, that I think we need to talk about a lot more. What we're seeing is that adults are having difficulties regulating their own emotions. We see that, within divisive banter, even with colleagues, or even within just education systems. And so I guess my question is that if we know that our children are having major concerns, ability to access mental health, being able to actually ask for help, being able to know where to go, we're also seeing the same thing with our adults. And I think that is something that I know many people would not want to share, but that's my reality. And so what are we doing to be able to actually support our colleagues, our friends? And are we actually teaching, if we're not teaching the empathy skills, does that mean that we also aren't really showing empathy for others? And that's my biggest concern. Because that's my reality, unfortunately, right now.
Absolutely. We're gonna transition. It's gonna be a really hard pivot because I know we're on like a tight schedule for time. I'm gonna ask my staff to come up to the stage really quickly so that we can move into Q&A from the audience and online. But I will say this as they come up. We have a white paper that frames this at a high level. And now we will be releasing today the full report on the website that goes really deep into this. And then the next step that we do, as you saw in our 4 pillars of impact, really speaks to the policy and implications piece. And so the next thing that will be coming out will be a policy brief that is more targeted, Paula, to your point, and Tom, to your point, more targeted as to, so what do we do in the context of Spartanburg? Thank you, sorry. I meant to click that earlier, but we were deep in it. Colin had me so focused. We can blame everything on Colin now.
You can.
So I'm gonna open it up. Questions, general comments, thoughts, feedback for panel, for the team, overall, with the presentation and the report itself. And we also have online. So online, if you have any questions, please jump in the chat and drop them.
Yeah, so thank you for doing this, or thank you for being a part of this, or being asked to be a part of this, if I'm told. But my question, you guys had a lot of great information or gave up a lot of information, and I'm trying to figure out where it's like jump to. But I wanted to go to, like Lori brought up, well, I should say Dr. Thornton, brought up like the gap in care, which is like specifically like the queer, Latino, rural communities. But then also Colin brought up, well, I should say first, Polly brought up like the sense of belonging. And I'm tying all this together, I promise. So then like Colin brought up with like that he's the D7 wellness and behavior coordinator. So what I'm trying to get to is things like programs like safe zones or programs or any other programs. I'm really specifically moving into the safe zones. What are we doing to help make sure that it's already implemented in the schools? Because my mom was a past D7 teacher, and she was one of the very few teachers that did the safe zone. So my question is saying, what are we doing to implement this throughout all of D7 to make sure that all teachers are certified or trained in safe zoning? Because as a queer person and working with queer children, and talking to them and really being with them through Uplift, they need this. Not even just the queer students, Latinx students need a safe zone, Black students need a safe zone. Even like the small Cambodian community that we have here in Spartanburg, they need a safe zone as well. So with the policies that are going all around the country, what are we doing? That's pretty much like what my question is.
Well, that's great.
Well, anybody, because I want everyone here.
So let me just say this. What are we doing to be different of what should be done? So let me make that very clear. What I think should be done, and I'm telling you this as Colin, even though I know I work at D7, I've been in other districts where it is extremely important that everyone feels safe in coming in, especially if you are identified as, or you identify yourself as LGBTQI+, is that you have a place. That you have a place that you know that you're not going to be judged, that you feel free or safe, that you are safe, emotionally safe, and that you have an ally, and that you have a person that truly, truly is going to allow you to be in that space and look at you for who you are. Is that happening everywhere? No. So that gets into really more of politics, that gets into more of like discretion principles, that gets into more of the protocols and all the different things way above. But what I'm saying is that I do know of a few school counselors. I know of a few teachers. I know of a few maybe ambassadors that really, really are ensuring that students know who they are, that they can actually be safe spots for them. I do not know how long they're going to be allowed to keep the safe space triangle on their doors. I haven't asked the question.
You don't, I wouldn't.
But I will be very honest with you, is that it comes back down to that we need to serve, and this is me, and this is actually, I can speak for, so I've even heard my boss, Nicole Thompson, our Executive Director of Student Services. We serve all students, period. We serve all students. If any student that's coming through our door and that we need to support them academically, that's the law, we have to. If we have students that are in crisis, regardless of who they are, not only is it the law, it's ethics. We're gonna do what's right, and we train them, and we train our personnel, and we've expanded personnel to be able to treat everyone, regardless. So, to answer your question without answering your question, we're going to serve all students, period. And that's the expectation.
Thank you. Any other questions from the audience here? Anything online, Josh?
Yeah, I had one earlier from Emily Fish. The question is, does anyone have any info on how food insecurity could be impacting some of the stress and mental health concerns for students? Do they believe this plays any role in students' mental health concerns?
So for online, well, never mind, you all see the question in the chat. Apologies. Go ahead.
Yeah, I mean, absolutely. I believe that food insecurity does play into it, and that's something that needs to be addressed. I mean, the way our body's fueled, fuels our brain, it fuels our emotions. When we're tired, we're cranky, all of us. And so I think that anxiety, especially when kids do not know what they're gonna have for dinner or what they're going, or that they come to school hungry. I mean, that's going to affect them definitely educationally, their ability to focus, but it's also going to impact that anxiety that they feel. It's going to play into their depression, the way that they just feel emotionally all around. And so I think that goes hand in hand, is addressing some of the food insecurity that we have. If they go home on the weekend and know that I know that sometimes in schools, they send food bags home with certain students. And I think looking at ways that we can continue to address the whole child is very important.
To piggyback off of that, I think that when we talk about adolescent health and wellness and focused on the health of young people, the Maslow's hierarchical of needs is that basic needs have to be met first. If basic needs are not being met first, they are in survival mode, which means it'll be harder for them to cope, harder for them to process emotions, and because they are in survival. So meeting the basic needs of a young person when it comes to their health and wellness, mental health, physical health, all of the whole child, is critically important.
Mhm.
So from the research perspective, so what we know, even though the relationship is kind of inconclusive, like eating vegetables and fruits, we included that in our analysis, and we didn't find significance, statistical significance. However, what research informs us, the previous research, is that there are some indirect effects of lack of eating vegetables and fruits from the nutritional perspective. So it degrades our health and physical health, and when physical health is degraded, that affects our mental health as well. And also the whole idea of being insecure from the basic needs is also creating stress. So that is direct psychological connection between food insecurity and mental problems in the youth.
Yeah. One of the things we talk about a lot in the research around just poverty in general is poverty is a compounding effect, right? And so that internalization of external stigma of being impoverished in and of itself is a multiplier effect to the other things that are already happening. And so thank you for bringing that up, Bilal.
And also the research elsewhere done included like parental income and education, so which are not included in the YRBS survey. So most research informs that like parental income and education have like significant effects on children's mental well-being. So that's not part of our analysis, but we know that from research. But and these are immensely important under the like the overarching idea of poverty, which is related to food insecurity.
Yeah. Keith. Thank you.
Yeah, the proposal of YRBS being amongst all school districts in the future. I'm interested in y'all's work, if you've seen areas to where this instrument can be improved as we move towards a localized YRBS.
Yeah, you open up a can of worms. So, because you ask researchers how to improve research. I think we've spoken about a lot of things, but I've spoken enough. I'll let staff. Because Bilal, you can go, because you've gone in on the data a lot.
Yes, as we know that we have like 3 years of data, and we'd love to have like more years of data, and especially tracking down on how we are doing all the inputs that are putting in place, and then it's like how we are improving, not just on the outcomes, but also on the factors that are producing the outcomes. So definitely, I do not know how like the administrative procedures, the funding, etc. But I know that we need to know like how, for example, we have found like observed the screen time, physical activity, all those kind of stuff. So they are like affecting significantly the mental health outcomes. So then we need inputs in those areas at all levels, like schools, in families, parents, and healthcare systems. So so I was working on that, and I found that, like for example, parents' screen time. So research found that if the parents have like higher levels of screen time, that is significantly related to the higher levels of screen time for the kids. So we have that role from the parents, right, and from the children, and then without the proper awareness and education. They even do not know. They might be interested in reducing screen time from the children, but they might not realize that they are themselves doing a great level of screen time, which is bad for their own mental health and also for the kids. So then in the future, with more awareness and education in the school systems, in the healthcare systems, health professionals, so we'd be interested in knowing how we are reducing the screen time from the kids with all those inputs. So they are absolutely necessary for the future. Yeah.
So the only thing I say as we wrap up the Q&A portion, so we can do our formal farewell to get you out on time, is that for me, I would love to see, because we see a lot of time series data in this, but we can't say longitudinal because we can't pinpoint. Like, I would love if over the course of the education system in Spartanburg County, like I would say K-12. If we can have actual longitudinal data on a subset of the population. So from the moment you enter your school system to you graduate, we can see year over year what is happening, and then we can be more granular about our interventions instead of very broad. With that, I want to say thank you to the panel, thank you to the staff, and can we give them a hand?
Wanted to say that, I know.
I know. So I want to close out with a few thoughts. And as we bring the event itself, sorry, you all, come on with me. I'll make sure everybody's together. Welcome. As we bring the event itself to a close, I want to end where we began, with gratitude. So as you see on here is a partner spotlight of all the folks who made this possible. So thank you to every leader, partner, educator, mental health professional, caregiver, most importantly, every young person who helped make this report and this gathering possible itself. We begin this morning by acknowledging that this is not just a report, but a reflection, a mirror held up to our systems, our structures, and sometimes even ourselves. It's an honest account of what our youth are facing and what they're asking from us as they face it. Throughout today, we've heard the data, we've listened to the stories, we sat with the weight of what was shared, from the isolation to pain to this need for individualized power and support. And I hope that you leave not just informed, but moved. Because the question now is, and as we said on the panel, what do we do? Bless you. Will we create pathways that don't just treat crises, but prevent them? Will we amplify youth voices in rooms where decisions are being made? Will we fight for access, for dignity, for culturally grounded care? Not someday, but now. At Strategic Spartanburg, we believe that research is only as powerful as the action it inspires. The launch is not the finish line, it is a rallying point. So let's honor the voices we heard today by doing what the moment calls for. Listening deeper, collaborating harder, and acting bolder together. On behalf of the entire team, thank you for showing up, not just today, but for all the steps to come. Let's make the youth in our community know that they are seen, they're valued, and they're never, ever alone. We are in this with them all the way. Thank you for being here today, and let's keep building. Thank you all online.